All right, good afternoon, everyone. We will go ahead and get started. Thanks again for joining us. My name is Danae Aber. I'm the Executive Director of the Louisiana Rural Health Association. Thank you for joining us for this webinar, Pricing Transparency and Good Faith Estimate for Rural Health Clinics. LRHA is happy to host this webinar presented by Sarah Homan with the National Association of Rural Health Clinics. This webinar is being recorded and will be available along with a copy of the slides on the webinar recordings page of our website, and I will drop a direct link in the chat to the relevant page. Your lines should have been muted automatically when you joined. Please remain on mute to prevent background noise and enter any questions that you may have in the Q&A box at the bottom. After the webinar, you should automatically receive a survey pop open in your internet browser. We do ask that you please complete that survey. It helps us to continue to improve future events and identify future education topics. So with that, I'd like to welcome Sarah Homan. Sarah is the Director of Government Affairs for the National Association of Rural Health Clinics. She leads both regulatory and legislative federal policy efforts for the organization and provides direct technical assistance and education to RHCs on COVID-19 allocations and other programs. Sarah advocates for reimbursement policies that incentivize and support rural primary care and other health services. Prior to joining NARHC, Sarah worked for the Pennsylvania State Office of Rural Health. She earned her Bachelor's of Science in Health Policy and Administration from Penn State University and her Master's of Public Health from Penn State College of Medicine. So thank you so much, Sarah, for being here, and I will hand it off to you.
Wonderful. Thank you so much for having me. It's good to be here. This topic is not necessarily anyone's favorite topic to discuss, but I kind of just wanted to start with a bit of a disclaimer that regardless of that, and not being everyone's favorite topic, we have our own kind of preferences and ideas around the feasibility of good faith estimate provisions and all of that, which we will get to. But I still think that it's incredibly important to have conversations like we're having today about what the current policy is, regardless of whether we fully support it or fully love it or not. It's important to know all those details. And so that's what I'm here today to walk through. I'm going to start with a bit of kind of a theoretical overview of what price transparency in healthcare is designed to be, why it's sort of the latest buzzword, if you want to use that term, the topic that members of Congress and agencies are kind of focusing on. The Association of American Medical Colleges defines price transparency in healthcare as readily available information on the price of healthcare services that, together with other information, helps define the value of those services and enables patients and other care purchasers to identify, compare, and choose providers that offer the desired level of value. So in a definition like that, in theory, price transparency in healthcare sounds pretty good, right? If we choose to be consumers that are, educated and essentially shop around for services, this sounds kind of ideal. The challenges that we're seeing since price transparency provisions, including the good faith estimate policies, went into effect is that not everything works like it does in perfectly crafted definitions and in theories and things like that. But I think it's helpful to kind of talk about why the focus is on this, sort of what the pressure on the industry was and why members of Congress started to look towards, well, maybe price transparency is a good option in addressing the cost of healthcare. So national health expenditures in the United States are higher than all other countries, and that doesn't necessarily translate to, as you know, you've likely seen all of these statistics before, but that doesn't necessarily translate to greater health outcomes, higher life expectancies, things like that. And so this is not the first time that Congress has sort of had an idea to their attempt to find the silver bullet, if you will, to address the rising costs of healthcare. In 2021, the national health expenditures was 4.3 trillion. I just read something this morning that healthcare spending is predicted to be 7.2 trillion by 2031. And so it just continues to increase year after year. And what they're finding is that these drastic increases in the cost of healthcare are not necessarily because patients are receiving more services, nor is it necessarily tied to better health outcomes, but the costs continue to increase, including the costs to patients. And so the kind of idea behind this is that price transparency exists in other industries. For example, if you need to have some non-emergent repairs done to your vehicle or to something in your home, and you have the option to get quotes from folks to essentially shop around. So the idea is that price transparency like that, shoppable services essentially, exists in other industries, and why have we not sort of attempted it in healthcare quite yet? The reason is because healthcare can be a lot more complex and nuanced than that. But regardless, this is sort of the direction that Congress decided to go. I mentioned this briefly before, but not just was the the cost of healthcare increasing dramatically for payers, and obviously the federal government is a major payer of healthcare, but it was also being shown in significant increases to patient out-of-pocket costs through their copays and deductibles, and that, in theory, in part, is making patients pay more attention to these costs and perhaps to some potential solutions. The theoretical ideas behind the benefits of price transparency in healthcare is that in an ideal world, requirements around price transparency, hospitals posting their prices, clinics and other providers issuing good faith estimates so that patients can be more aware. So that pressure is increased on the providers and insurers. And the idea is that if patients have that information, they'll be informed and empowered to shop for healthcare services in, like I said before, non-emergent situations. So the idea is that, if consumers are price conscious, then they're going to want to seek their care at the place that they can get the highest quality care for the lowest cost, because they know what it will cost them to get a knee replacement done, for example, at X, Y, and Z locations, as opposed to before they had no information or no ability to get that information to shop around. Still, the theoretical impacts from that are that if patients are price conscious consumers, they're shopping around, it's going to stimulate greater competition amongst plans and providers, ultimately based on cost and value. Again, these are all theoretical impacts behind why price transparency was sort of the next option that Congress decided to try around the rising costs of healthcare and tackling those. This is, in a perfect world, in a pretty painted picture. This is not necessarily the experience of providers and patients. This obviously theoretical kind of flow chart does not address the fact that perhaps patients aren't interested in shopping around for services. They have never done so before, and perhaps they have no interest in just one more thing on their plate. It also doesn't take into account the niche perspectives of providers like you, our rural providers, who, even if their patients are perhaps interested in being price conscious consumers, if you are the only clinic in a 50-mile radius or even greater, then it's unlikely that your patients are going to use that good faith estimate or use those posted lists of prices to shop around, because there just perhaps are not other options for them. And still, kind of ideas in the price transparency space don't necessarily take into account what was being done kind of without regulation. So I talked to a lot of clinics who say, if a patient asked for an estimate about what their cost of care would be, we had no problem providing it to them, but now we're required to do it for these patients and in situations where it doesn't make sense. And because our patients didn't ask for these good faith estimates, they're very confused by what they're getting. And we'll get into all those requirements in just a few minutes, but I think it's important to start with sort of where Congress's head was at. This has been a decades-long process, and it's a very bipartisan issue. Folks on both sides of the aisle are very, very supportive of price transparency, at least sort of trying this as an option to address the rising cost of healthcare. But perhaps, not everything works like it does in theory. So let's get into the actual provisions. The No Surprises Act was passed in December of 2020. This was after, like I said, over a decade of work spanning multiple administrations, multiple congressional cycles. Lots of folks put a lot of work into this piece of federal legislation, and it was called the No Surprises Act. And the majority of this bill was around hospital price transparency provisions in the balance billing space. These provisions apply very specifically to very specific qualified facilities. So hospitals, hospital outpatient departments, critical access hospitals are part of that, and ambulatory surgical centers. Because they're very specific in the facilities that these provisions apply to, it's pretty clear that rural health clinics are not classified as facilities for the purposes of these provisions. So this was the bulk of the No Surprises Act in the balance billing space. It does not apply to RHCs. I'm not going to dive into these provisions just because I want to focus on what does apply to RHCs here. And I know that today has some other resources for you in this space as well, if you're interested in kind of the hospital requirement side of things. But like I said, the bulk of the bill was around balance billing, and that does not apply to RHCs. However, the piece that does apply to RHCs and to all providers is the good faith estimate provisions of the No Surprises Act. And so I'm going to talk today about, what it looks like or perhaps doesn't look like in a rural health clinic, and what the requirements are for you all. But I just want to emphasize that good faith estimate requirements and provisions are not solely a requirement for rural health clinics. They're not solely a requirement for any type of safety net provider, but they do apply to all providers. And so that loops RHCs into it. So when I say requirements for RHCs, know that that's for all providers. But it, of course, does include providers in rural health clinics. Okay. So the first piece around what's required as part of the good faith estimate provisions is the notice of the availability of good faith estimates and the patients that are eligible to receive them. So rural health clinics, again, all providers, but I'll specify just rural health clinics for today, are required to display basically a notice about the availability of good faith estimates to eligible patients on your website, if you have one, in your office, and then other places in your front office, and then also in places where scheduling and cost of services conversations occur. So if perhaps you have a back room or an office space where you may help individuals sign up for insurance or whatever it may be, that's a place where a notice like this would need to be listed. It is not required that this notice be in X number of languages or whatever it may be, but CMS does say that the notice must be available in accessible formats and languages spoken by the individuals considering or scheduling items or services. So your patient population, and you can modify that accordingly or have in different languages accordingly. On the right-hand side of your screen is an option, a template for what this notice could look like. CMS provided this. If you have the same kind of general information, it's not necessarily required that you use this exact one. You can certainly modify as you see fit, but ultimately the notice that good faith estimates are available to eligible patients should be included on that required notice that's posted in your facility. Oh, and I should have mentioned this before we got started, just to reiterate, but I'm happy to take questions about these topics and about this presentation. Danae is going to be monitoring the chat and the Q&A throughout the presentation. So if it's a question that or if it's kind of a topic in the space that you haven't seen pop up on my slides yet, I just ask that you hold your question because perhaps I'll answer it throughout the rest of the presentation, but then there will certainly be plenty of time for Q&A. But if it's something that's just unclear that is on my slides or something like that while I'm on the slide, don't hesitate to put that in there and she'll let me know and we can clarify that. Okay. So I've used the term good faith estimate quite a bit and this requirement. If you're new to the RHC space, or perhaps you just are new to kind of compliance in terms of some of these provisions, a good faith estimate is essentially what it says. It's an estimate of the charges associated with items and services that are reasonably expected to be furnished to uninsured patients and self-pay patients. So as of right now, the requirements that are out there currently, that's who are eligible for good faith estimates. Uninsured patients is a bit more self-explanatory, but self-pay patients are patients who have health insurance, but for whatever reason, do not wish to have a claim submitted to their insurer for the specific items or services that they're scheduling an appointment for or requesting kind of an expected summary of charges for. And so essentially, actually, this is not my next slide. Yeah. So good faith estimates need to be issued to those patient populations, uninsured or self-pay patients that either request a good faith estimate or who schedule an appointment 3 or more days in advance. And this policy has been in place since January 1st of 2022, this requirement. A quick note is that these requirements don't apply to beneficiaries in Medicare, Medicaid, and other federal insurance programs. Congress and CMS have said that those beneficiaries have essentially separate price transparency protections or patient protections in that space. And so these do not apply to them. But the timelines in which good faith estimates need to be issued is to those patient populations who qualify is pretty quick, as you can see on the table on your screen. If a patient schedules an appointment 10 or more business days in advance, that good faith estimate needs to be provided to them within 3 business days of scheduling, 3 to 9 business days in advance within 1 business day of scheduling. These are, I'll just be honest, these are crazy quick timelines that aren't necessarily always feasible. In our clinics, we know that. But again, I'm just presenting the information to you as it stands in the law. There are certain, so just as a quick aside, so these requirements came from law. So Congress passed the No Surprises Act, and many of these kind of details around good faith estimate requirements were very explicitly laid out in the law. Oftentimes in legislation, Congress will be semi-vague in something, but they'll direct CMS or another agency to kind of detail all those specifics out for providers or whoever it may be. In this case, there were a few areas where CMS kind of used their authority to provide additional details, but Congress was very, very explicit on a lot of these requirements in the bill itself. And because of that, the process for any changes to this look a little bit different. You know, CMS sometimes has the authority to issue additional guidance on things. For a lot of these pieces to ever change, if they would, it would need to come through additional legislation passed by Congress. So just wanted to kind of clarify that, where the sort of jurisdiction lies here. If a patient schedules an appointment less than 3 business days in advance, they do not, and they're uninsured or self-pay, you do not, it doesn't trigger essentially the requirement to create a good faith estimate. And then lastly, when a patient requests a good faith estimate, it must be issued within 3 business days of the request. So just as a quick reminder, uninsured or self-pay patients are eligible for good faith estimates if they request that GFE, or if they schedule an appointment, or if they schedule an appointment 3 or more days in advance. Unfortunately, good faith estimates are not optional. So I've had folks ask, you know, if I'm happy to provide these when, you know, a patient specifically requests one. But you know, it's kind of confusing to me that if they don't want one, they still have to be given one. Again, that's just how the policy stands right now. They're eligible for one if they're uninsured or self-pay. They're eligible for a good faith estimate, of course, if they request it, but also that scheduling of an appointment 3 or more days in advance, if they're in one of those populations, then it automatically should trigger the creation of a good faith estimate, regardless of whether they ask for it. And so we certainly do hear that, you know, patients are confused by what they're receiving. They think that it's perhaps a bill for services, even though they haven't received them yet. There's a bit of confusion when, you know, they're given to patients who didn't necessarily ask for them. But unfortunately, as of right now, good faith estimates are not optional. That scheduling of an appointment for uninsured or self-pay does trigger that request, or that creation of a good faith estimate. Good faith estimates can be provided either on paper or electronically. If a patient requests the good faith estimate to be given orally, perhaps over the phone, you can do that, but then you also need to follow up with it in writing, so either on paper or electronically. So oral can sort of be the first option, but then they do need to be followed up with. Okay, so now diving into what needs to be included in the good faith estimate. This is essentially where it gets increasingly complex and a bit subjective, which is one of the most challenging parts of this policy. A good faith estimate needs to include the primary service that the RHC expects to provide to the patient, essentially the initial reason for the visit, and then all other items and services that are reasonably expected to be provided in conjunction with the primary service during that period of care. And also list these services and then provide the charge information alongside it to be considered a good faith estimate of those expected charges. This is oftentimes the place where people will really start to jump out at this and have significant concerns about how, you know, a rural health clinic could be expected to, number one, know exactly what is going to be provided to that patient just from a single phone call, just from them scheduling that visit. We oftentimes have our non-clinical scheduling staff as the ones that are having these conversations and starting at least the process of creating a good faith estimate. And then based on what Congress has said needs to be included in a good faith estimate, it's a significant amount of pieces, and a lot of folks will say, well, it's not possible for us to include all of those things. And I hear those concerns. Those are ones that we've certainly pointed out time and time again. But again, it's how the policy stands right now. I will say that despite this being very, very subjective, right? What's reasonably expected, that can be defined a bit differently by everyone. If you reasonably expect that you're going to refer your patient to any type of specialist following their visit with you, if you can, at the time that they're scheduling an appointment, you can already reasonably expect that you're gonna have them follow up with a specialist, for example, that individual would then, that office would then be responsible for creating another good faith estimate with the services and charges that they expect to furnish when that patient either requests it from them or schedules an appointment 3 or more days in advance. So, it's a bit of a slippery slope. Like, how far do we reasonably expect an individual patient's care to go? Like, how much do we need to include in our initial good faith estimate is always really, really challenging. But I will say that, those additional visits, whether it's with your office or with a different provider, they would trigger their own separate, essentially, requirement to create another good faith estimate if the patient was still eligible for them as uninsured or self-pay. Just to harp on this a little bit more, reasonably expected is obviously a very subjective term, but it also really highlights the importance of documentation when that initial phone call is had. I know that some clinics and some other providers are integrating a lot of additional questions into their EMR if patients are scheduling their own appointments via the EMR. So that's, perhaps an option as well, but good faith estimates they're very clear about this, that they're to be based on the information the RHC has at the time the appointment was scheduled or the good faith estimate was requested. Again, this doesn't make it perfectly clear. Like I said, we have our non-clinical scheduling staff having these conversations. Perhaps the patient tells them just a small piece of what they're going to come in and present to your provider when they're in the room with the provider. Or perhaps they don't feel comfortable sharing that with the person that they're scheduling the appointment with. They say something completely different than what they present with, but the good faith estimate will be created based on what information the RHC has at the time that appointment was scheduled or the good faith estimate was requested. We know that patients come in and they've said one thing as the reason for their visit. They're in the room with the provider and they list a laundry list of concerns, pains, reasons that they're there that day. There's no way that your good faith estimate could reasonably include all of that information. That's not feasible. You're not mind readers, even though sometimes this policy makes us feel like we need to be. But just to continue to harp on this, it's really, really critical that whoever's having those initial conversations and beginning the good faith estimate, that they document very clearly that when Mr. Smith called, he said that his symptoms were XYZ, and that's why he wanted to be seen, and that's what we created the good faith estimate off of. Later, if the documentation by the provider says that they presented with a whole laundry list of things and the provider ordered tests according to what they learned when they were actually in the visit, those pieces of documentation are going to be really, really important if the patient goes through the enforcement process of this policy, which I'll talk about in just a minute. The expected charges that are supposed to be included on your good faith estimate is what the cash pay rate would be. So this would be your anticipated charges, including any discounts or adjustments. So if you have a sliding fee scale for your patients, then the good faith estimate would need to incorporate that sliding fee scale based on the patients that was offered to. I will provide a bunch of links in the slides at the end that has all CMS FAQs. FAQ number 4 specifically talks about sliding fee scales and good faith estimates. So I'd encourage you to take a look at that. And we can, of course, happy to talk more about that, but that's specifically where that information can be found. Okay, so this is a sample good faith estimate. You can see what's included on here. Initially, when these requirements came out, they said that diagnosis codes needed to be included on a good faith estimate. And, you know, as we all agree, that was, you know, even more impossible than the rest of the requirements in the good faith estimate space, because, you know, not only are you trying to reasonably predict what the patient is going to ultimately need, but, you know, non-clinical scheduling staff, it's incredibly inappropriate for them to be doing, for them to be providing diagnoses. I'm not clinical, and I certainly don't want to have that responsibility. And so they do have a section for a diagnosis code, you know, perhaps if it's a returning patient and, you know what their diagnoses are, and they could result in additional tests during the appointment, maybe then you could include it, but a diagnosis code is not always required on good faith estimates. Just a continued example, like I said, with the sample kind of notice of the availability of good faith estimates. In the beginning, you can create your own sort of based on the template and the list of things that CMS asks or requires to be included on a good faith estimate. You can use their template or you cannot. That's really up to you. There are 4, kind of 5 if you include the sub disclaimer, but there are a host of these required to be included alongside your good faith estimate. So most have, you know, if they're issued electronically, it's just an additional page tied to the good faith estimate, or obviously the same could be for printed. But essentially these disclaimers are just emphasizing that good faith estimates are estimates done in good faith. The estimate could differ from what ultimately is provided to the patient. It should provide a disclaimer about the dispute resolution process. Again, we'll talk about that shortly. And then also that the good faith estimate is not a contract or a bill, and patients aren't required to obtain the services included on a good faith estimate just because they receive that GFE. So they should be included every time that you issue a good faith estimate to a patient. Okay, so I said I'd talk about enforcement. Enforcement of good faith estimate requirements are not done as part of your RHC survey and certification process or something else in that space. They are, so far at this time, since these policies went into effect at the beginning of last year, done through a patient-initiated dispute resolution process. Essentially, this process is intended to work by if after getting a bill for the services that they received, a patient, what's on the bill is $400 or more, in excess of what was included on the good faith estimate. A patient can request a dispute resolution process done through an independent third party, that those folks review the entire case and determine what the appropriate payment should be. This is essentially what it looks like online. It explains to the patient all that they need to start the process. So they need a good faith estimate to start the process. It needs to be within the last 4 months. The differential between the good faith estimate and the bill that they received needs to be at least $400. And they need to be uninsured or self-pay. And so then they click that start a dispute online. They pay a $25 administrative fee. The third party reviews what they provided. It reviews the documentation that you keep on this, which is why I continued to harp on that before. It's really important that you have that documentation so that you can essentially say, yes, well, this bill includes XYZ services and charges, but based on how the patient presented or scheduled their appointment prior to coming in and having additional complaints and reasons to be seen, this is what we created the good faith estimate off of. It's really important that your documentation exists so that they can essentially compare all of those pieces and ultimately determine the appropriate payment that the patient should be responsible for. There's another semi-new kind of process available to patients too. And this is a complaint process that essentially if a patient believes that they should have received a good faith estimate, so they're uninsured or self-pay, but they didn't get one from the provider, they can essentially issue a complaint to the CMS No Surprises Act help desk. That process I haven't heard a ton about. I also, in just the enforcement space broadly, I've heard of a few, but not very many of essentially patients taking their providers through that dispute resolution process. I've heard of a few where the patient didn't have all the information they needed. I've heard of some where the process started and then ultimately, I believe the patient didn't elect to continue with the process. So all varies a bit. I think it's, not super common in part because patients don't entirely know of what their sort of rights are under these new policies. And so perhaps as, more people learn that this is available to them, that may increase the number of disputes that are occurring. But I haven't heard much about the complaint process of patients sort of going through this either. Good faith estimates need to be included in the patient's medical record and available upon request for a minimum of 6 years after they're issued. So what I've talked about so far, all of these requirements that, like I said, have been in place since January 1st of 2022 are what we call phase 1 of the No Surprises Act regulation in the good faith estimate space. Essentially, the good faith estimate that your provider is responsible for is about their own services and charges. So those provided within your RHC by your RHC providers. There is essentially a second piece that Congress included in this legislation, second and third piece actually, that Congress included in the legislation, but CMS has basically said it's not reasonable for us to put these pieces into effect quite yet. And so they've delayed some additional requirements. I don't want to go too much into what those additional requirements may or may not be, because at this time they've been indefinitely delayed, meaning we don't have a date of when any of these would actually go into effect. And so until we get to that point, I essentially don't want to, kind of spark panic. I think there's going to be a lot of potential changes to these, like what we call them as phase 2 and phase 3 of good faith estimate policy. Likely there's going to be changes to them if they would go into effect. And the only somewhat movement that we've heard in this space is that CMS is expected to release a proposed rule with the advanced explanation of benefits requirements sometime in March of this coming year. It's positive. It's not necessarily positive that they're moving forward with some of these additional requirements. However, like I mentioned earlier, because Congress did pass this legislation, they CMS is responsible for putting it into effect or going back to Congress and saying, this isn't feasible. We need you to essentially rewrite the law. But it is positive in the sense that they are, starting this process through a proposed rule. A proposed rule gives individuals in industry, folks like us, folks like you, the opportunity to comment on sort of what they're proposing. And it's just another essentially formal way of making kind of our perspectives in this space known, as opposed to CMS just issuing a final rule that says, yeah, this is how it's going to be. This is what the policy is. So a proposed rule gives individuals an opportunity to kind of share with CMS what the impacts actually would be or are with even the parts of good faith estimate policy that are in place at this point. Okay, so I started with kind of a theoretical focus, and then I moved into what the requirements actually are. And now I'm kind of going to zoom back out a little bit to look at the impacts and the data that we've seen thus far, and really where we expect price transparency policy to head in the future. I've said this before, and I really want to reiterate it. This continues to be a bipartisan focus. So whether price transparency policies broadly, which personally, I don't necessarily think they are, but whether price transparency policies broadly are the silver bullet in addressing the rising cost of healthcare or not, Congress is united in their interests to at least try to see if price transparency policies can move the needle. So Congress is not united, as many of you know, on a lot of policies, and things can move pretty slow at times, but on not all of the specifics, but on the topic broadly of price transparency and the benefits of it, Congress is united and interested in pursuing that, to see if it has an impact. We have really minimal data thus far. Obviously, these provisions have only been a requirement since the beginning of 2022. So not a lot of time to gather information, but the Congressional Budget Office released a report late last year, essentially saying that if all price transparency policies, so not just good faith estimate policy, but all good faith estimate policies were perfectly implemented. So that means that every patient who was eligible to receive a good faith estimate received one. Every hospital that was required to post their prices in a very specific format, they did that. Essentially, the Congressional Budget Office modeled this all out and said that if all of them were perfectly implemented, they had the potential to reduce prices by just 0.1% to 1%. And so that's very, very small. Obviously, this is a model. Proponents of good faith estimate and other price transparency policies will kind of have their own rebuttals to this, as we all do to different policies that we don't necessarily agree with statements of and things like that. But I think it's important to note that this is the data we have, and they're saying, at this point, obviously it's new, but they're saying that even if everything was perfectly implemented, it would have such a small effect on reducing prices. That doesn't necessarily mean that, Congress is going to give it up immediately. Like I kind of mentioned, they, it's still early and they can, rebut some of the CBO models and assumptions made. But ultimately, I think this is an interesting report from the Congressional Budget Office. And then there's the other side of it, right? I said to start this out, in theory, it relies a lot on the patient's interest in being an educated and price-conscious consumer. And, there's a big question of, do patients even care about this? Are they interested in attempting to be price-conscious consumers? Are they interested in shopping around. And here too, we see really split data. On one side, groups like patients' rights advocates and a group called Power to the Patients, say that it's our right. And they claim that 87% of patients would shop around if posted prices were available. 91% of patients support price transparency in healthcare. Maybe they support price transparency in healthcare in the theoretical sense that, we all are supportive of too, but maybe just not in the way that it's currently being done. But then on the flip side of that, a recent Kaiser Family Foundation poll said that only 1 in 10 of their respondents were even aware of, now this is hospital disclosure requirements, so a little bit different than good faith estimate, but all in the same sphere. And also that 85% of respondents don't shop around for best priced care, even if they had the resources and the documentation to be able to do so. So despite a lot of this being pretty new, people are pretty split in what kind of, do patients care? Does it move the needle? Will it be that silver bullet? Alone, I don't think it's likely that, price transparency provisions will be that silver bullet, but a lot of that, I guess, remains to be seen too. It said that we had a variety of resources available too, so I'll show you what an RHC has first, and then move into kind of what's all the CMS resources that are out there. I just want to say that, from the standpoint of, what's best for our patients, price transparency could have positive impacts. Again, some of that's theoretical, some of that is CMS and Congress maybe didn't focus on the provider and patient voice enough in developing these policies. We're not against price transparency policies broadly, but we're against those that are increasingly administratively burdensome, and that don't, perhaps benefit the patients as much as they're intended to. If a patient's confused because they're getting a good faith estimate that they didn't request, is that best for the patient, or is that just confusing and more work for everybody? And so in our conversations with CMS, it's important to, I think, reiterate to them that, there is a perhaps positive intent behind a lot of these policies, but it's really important that they take into account all provider perspectives, as opposed to, kind of a one size fits all approach that they believe will be best for patients and providers. And then these are all the good faith estimate resources that CMS has released. You can see the regulations, CMS's overview of that, links to that dispute resolution process that I highlighted. All those templates that I talked about are downloadable there as well. CMS has done a host of webinars themselves. And then I mentioned all of those FAQs in the space. We've talked through a lot of what they share in those FAQs in this presentation, but that fourth one I mentioned before is the one that talks about integration of sliding fee scales into your good faith estimate. Okay, that's all the prepared content I have, but happy to answer some questions.
Yeah, we do have some questions here. I will just remind everyone these slides will be available. I know the last couple ones had links on there. So they will be available on that webinar recordings page within the next couple of days or so. So you can hyperlink out to those websites and those FAQs and resources. So the first question here, and you did speak to it a little bit, Sarah, but you may want to provide a little bit more detail on what specifically needs to be documented and recorded to prove that the GFE was provided.
Yeah, it's a good question. It's gonna look a little bit different depending on, whether you primarily document in your EMR, if you still have some paper charts or whatever that may look like for you, if your patients are accessing their documents and things like that through a patient portal. It's an option for you to upload the good faith estimate to the patient portal. And then of course that would be dated, and the upload would be it would be a bit clearer when that was issued. And then if that's not the process you go through, if you're printing them and giving them to the patient, if you're mailing them to the patient, I would just ensure that on the back end, perhaps you develop some type of process. Again, looks a little bit different for everybody, but you develop some type of process where you've determined this patient is eligible for a good faith estimate, and they were provided with this good faith estimate on X date when they requested it, or they scheduled an appointment beforehand. So I can't perfectly answer that question because it looks a little bit different for everybody, but those are a couple options that I've seen.
Okay. The next question is related to the what's reasonably expected. So the question is basically, how can this be done? We provide care to patients who choose us as their provider. At the initial visit, we may not know what other procedures, et cetera, the patient might need. The care and resultant follow-up care are an evolving process.
100%. I mean, you're really with that question emphasizing the issues with this policy. I'll be just completely frank about that. We don't know how to, diagnose our patient, know all that they're going to need in an individual visit, by just a phone call. So I think, that's why what you document at that phone call is so critically important. If that patient, you document that is a new patient, that they shared XYZ thing with you, this is going to be an initial visit. You can put, one of the disclaimers that you need to have on your good faith estimate is that, this is perhaps not indicative of kind of the full suite of things that may be done during a visit. It can't possibly be. So that part of the disclaimer is what CMS requires. Additional pieces that you choose to add to that disclaimer are up to you. So I do encourage clinics to kind of elaborate on those a little bit more. We are including on here what you've shared with us when you scheduled that appointment, but based on, that provider-patient relationship, there may be additional things done. And so that's kind of the best that you can do. And you have to essentially, trust that your documentation supports the process that you're going through. Like I said, because this isn't part of, RHC, it's not a required component of RHC policies and procedures or anything like that, but I do really encourage you to have a process that you follow in this space, just to ensure that it's done the same for all of your patients that may be eligible for this, and that you've checked the boxes to protect yourself, and that you have that documentation if that patient would go through the dispute resolution process, that you have the documentation that says, yeah, this is a new patient, and all they told me was that they've been having some occasional headaches. And then they come in the room with your provider and they say, yeah, I have consistent headaches. I also have this spot on my leg I want you to look at, and a whole host of other things, which we know that they come in the room with your providers and they share these, all of these things. And so that documentation is obviously going to look kind of much broader and different than what the documentation you had at that initial phone call or whatever it is may look like. And that's one of the things that you can highlight in the documentation if you have to go through the dispute resolution process.
That actually leads it to a couple questions that I personally have, if you don't mind. Is there a definition of what they mean by in conjunction with?
No.
Fantastic.
There's not.
And then speaking to, you talked about when a referral is made. And so like saying, we can reasonably expect that, you're coming in for XYZ, we're anticipating a referral. How much onus is on the referring provider in that process of making that referral and ensuring that a good faith estimate for that next stage is done? Is
Yeah.
it just you make the referral and the onus is on the provider you're referring to, or do you have to let them know that the patient is self-pay? What's that onus on the referring provider there?
Right. Yeah, that's a great question. So, because the good faith estimate requirements apply to all providers, that onus is then on the next provider or the next office that patient would be scheduling an appointment with or requesting a good faith estimate through. Essentially, that provider that then sees the patient in a follow-up would then be subject to the same requirements to see if that patient is uninsured or self-pay, issue a good faith estimate to them, all that kind of thing. It's, it's one of those areas where within a period of care and that's the next provider's kind of responsibility really butt up against each other. But I think that it's sort of a safe transition of responsibility when, that provider would then be responsible for that next step. Because if a patient's going to be scheduling another appointment with that other office, that office would have all the same responsibilities that your RHC did in the first place.
And I think that kind of answers this next question, which is, do all of these regulations apply to non-RHC fee-for-service clinics and providers?
They do. Yep.
The next question, can you be more specific on the statement made about the good faith estimate needing to be documented in the medical record? Where specifically in the record would this need to be documented?
I don't have a perfect answer for this, just given that all will probably look a little bit different. But essentially any other, I'm not clinical, so I'm not entirely familiar with what some of like the other, documents you may have that are part of that patient's file essentially may be, but this would just be another thing that needs to be available to that patient for the next 6 years. So, if it's more in an auditing sense, I think, if you would be audited on good faith estimate policies, if it would come to that. It hasn't at this point, as far as I've heard, but that it would be available within kind of the patient's file, is how CMS talks about this.
The next question here, patients change insurance all the time. If there's a change in the insurance, do we have to ask if the patient does not want us to file the charges with the new insurance and then issue a new GFE?
Yeah. So the process that CMS recommends that people follow, is that every time any patient, schedules an appointment 3 or more days in advance, or of course would request, is that whoever's having that conversation, or if it's done, through the patient portal, that the flow is set up this way, that the patient is asked every time if they have insurance, and if they have insurance, do they wish to have a claim for this item or service submitted to their insurer, for this specific item or service that they're calling to schedule. That kind of flow process will either trigger you to create a good faith estimate, obviously, if they say that they don't have insurance, or if you ask them if they want a claim to be submitted for their insurer and they say no, then they would fall in that self-pay bucket. And CMS does say that this conversation, or this flow should happen every time, given the fact that patients do change insurance. From what we hear, if you ask a patient if they want to have a claim submitted to their insurer, and they are insured, like, they're going to be surprised by that question and very often say, well, what do you mean? Like, of course I have insurance, I want it to be submitted. But that is an option for them to be self-pay. And again, perhaps as patients become more aware of kind of these options, to be self-pay and to shop around a bit, that will become, they'll more frequently kind of say no, that they don't want that claim to be submitted, so that they're eligible for a GFE. But At this point, I think patients are surprised to hear that line of questioning, and they say yes, that they want it to be submitted.
Yeah, and then the last question I have here is, if a procedure is being scheduled that would require anesthesia, what responsibility would a co-provider have regarding the GFE?
I'm sorry, can you repeat that?
Yeah, if a procedure is being scheduled that would require anesthesia, what responsibility would a co-provider have regarding the GFE? Matt, I don't know if you mean like the GFE for the anesthesiologist, the person like
Yeah.
their GFE. I'm not sure if that's kind of what you're getting at with that question.
Yeah, so if they're done, if it's all in, a single procedure, then all within that would need to be included on the good faith estimate. That wouldn't be a co-provider example. A co-provider example, the way that CMS defines it is, that's the case where that you're going to be referring a patient to somebody else. That provider that you're referring to would be the co-provider or the co-facility. At this point, they're responsible for creating their own. But if it's like, I think your example is getting at, kind of a procedure in your facility.
Yeah, she did clarify she's referring to charges from the anesthesiologist.
Okay. So yeah, if they're all within one, then they would need to be, and that's, done in your rural health clinic as part of, that procedure that they're scheduling, or whatever it may be, then yes, they would need to include those charges as well.
Yeah, and she's saying for a procedure not done at the RHC. So I think if you're referring them, you're saying, hey, you need to go have this procedure. A lot of times, like the facility has a charge, and then the anesthesiologist is a separate charge, right? But I think the answer is going to be that onus is on the facility doing the procedure.
Yeah, especially if that's something that, they would then schedule separately. I think that's a good kind of break or like trigger for the other provider to create it, is if it's going to be scheduled separately, the process would kind of begin again.
Okay, hopefully that answers your question, Meta. We are a little bit past time. If you do have additional questions, feel free to email me, and we can try to get those answered for you. I know this is complicated, and we all have a lot of questions about it. I will say, we did speak to this issue when we were in DC in February, for the Policy Institute with NRHA, and I'm sure we'll be speaking to it again when we go back in next February for Rural Policy Institute. And then we will be keeping our eyes open for that proposed rule coming out in March, so that LRHA can make comments on that. So we will likely have a listening session open to our members. You guys can come in, and we can gather your feedback to provide comments on that proposed rule, so we can share all of these concerns that you're having about this good faith estimate and the difficulty of actually meeting these requirements. So any last comments, Sarah, before we close out for today?
No, none more for me. I do have to jump, but you all have my contact information and a phenomenal resource today as well. So thanks for having me. And I look forward to continuing these conversations with many of you.
Awesome. Well, thanks so much, Sarah, and thanks everyone for joining us. As a reminder, when you exit, a survey will pop up in your browser. Please complete that. I do review the feedback of every survey, so we can make sure that we provide you education that's valuable, and continue to improve each of our sessions. So the recording of this webinar will be up on our website within the next couple of days, probably early next week. And as always, please feel free to reach out to us at LRHA if we can be of any assistance. So thank you so much, and have a wonderful day.